Hi, I'm Steve Nichols from Adelaide, Australia. I'm here for EHJ today, and we're here at ESC 2014 with another really exciting trial presented, the STICS trial. I'm joined by Dr. Barbara Cassidy from Oxford, Dr. Paulus Kirchhoff from Birmingham, and would really like to kind of hear more about STICS. Dr. Cassidy, tell us about the trial.
STICS wanted to test whether intensive perioperative statin treatment would add to the management of patients undergoing cardiac surgery. There had been meta-analysis of small trials indicating that perioperative statin treatment had spectacular effects on postoperative atrial fibrillation and troponin release, something like 50% reduction in the new onset of atrial fibrillation and similar effects for troponin. But because the trial was small, they were not all randomized, blinded, and analyzed according to intention to treat, we wanted to basically have the definitive answer on this, and we ended up recruiting 1,900 patients thereabout, and this is an investigator-led trial and the fruit of a collaboration between the Fuwai Hospital in Beijing and the University of Oxford.
Right, so this was a study that was conducted essentially in China.
Correct.
Can you tell us a little bit more about the trial?
Yes, so the trial randomized, as I said, this number of patients to rosuvastatin, 20 milligrams daily, or placebo, started up to 8 days before cardiac surgery and continued for 5 days after that. The patients were all on sinus rhythm. This was one of the criteria, with no history of atrial fibrillation. And the main outcome were postoperative atrial fibrillation as assessed by Holter ECG for 5 days, and the troponin release as assessed by over a curve over 5 days again. Right. And then we had also we recorded other major in-hospital events and duration hospital stay and cholesterol and renal function.
And was it a combination of coronary and non-coronary cardiac surgery?
85% of patients had coronary surgery, and the rest had coronary and aortic valve or aortic valve only. So the vast majority were coronary artery bypass, 50% on pump and 50% off pump.
Right. So what did you find?
So we found that there was essentially no difference between groups, and about 20% of patients had postoperative atrial fibrillation in the placebo group and 21% in the rosuvastatin group. A number of predefined subgroup analyses also did not identify a particular subgroup of patients where this might have had a positive effect, and that was age, a duration of treatment before randomized treatment, before surgery, whether or not they had on-pump or off-pump surgery, all of these factors. And the same was true for the troponin. So we could not reproduce the spectacular beneficial effects that were reported before.
Yeah, were many of these patients on a statin beforehand?
Interesting question, because as this was China, only about 35% of patients were taking statin at the time of cardiac surgery. So the majority was statin naive. And in fact, that was one of our predefined subgroup criteria for subgroup analysis. And again, we did not see any difference between the patients who had been on statin before and those who were statin naive. To some extent, that also implies that stopping statin for a few days around surgery didn't seem to have any negative effect.
Right. So Paulus, what's your take on this?
Well, I think you can look at it from different angles. First of all, obviously, in the current AF guidelines from the ESC, we have a recommendation to say that you should consider statins based on the trials that Barbara has just described. And I think it illustrates how important, robust, and sufficiently powered and adequately performed trials are. Allow me to congratulate Barbara and the investigators in Fuwai and the team in Oxford for a marvelous study that provides definitive answer to a question that we hadn't gotten right in 2010 because we had to rely on the evidence that was available there. So I think if you look forward into the next guidelines, we'll probably not have that recommendation then. On the other hand, we will still want to reduce cardiovascular risk in AF patients. So I would I would not think that we will stop putting AF patients on statins if they are at risk for coronary events or for stroke. And that's still something that we need to do, and I think there is ample solid evidence for that. There is another way of looking at this, and I'm very much impressed that you did this trial in China. It must have been difficult, but I think it is in a way showing how we are coming together as a world. And I think when you read the news, you'll find that China is different from Europe, England, or wherever. But if you look at the patient characteristics of STICS compared to the older, smaller trials, apart from the fact that they were a bit younger, they are actually very similar. And the outcomes are impressive. Mortality is actually quite a bit lower than it was in the older trials. And the fact that 50% of the patients were on off-pump is certainly a sign of a modern surgical center. So I think they are data that are very relevant and valid for us. The third thing, and I mean that's something that Barbara may want to comment on, is that we had always thought, and there are consensus documents published on that, saying that, well, if inflammation has an impact on atrial fibrillation, post-operative AF should be the model of AF where anti-inflammatory interventions should prevent AF. And we all think that this short-term statin treatment is a relevant anti-inflammatory treatment. So is there a role for inflammation in the generation of AF or in the prevention of AF when it comes to treatment?
Well, there's trial with steroids in the post-operative period seems to suggest that there is, right? There is a reduction in post-operative atrial fibrillation. At least there is one trial published in JAMA, I think, that shows exactly that. We do see and continues to see in tissue and in biomarkers powerful effects, pleiotropic effects of statins. What we do not see, and we have been unable to see so far, and this is another trial that confirms this, is whether these pleiotropic effects are actually impacting on patients' outcomes. So they're there, but at the end of the day, it's still sustained LDL cholesterol reduction that makes up for the beneficial effects of statins.
And I think that really is a critical kind of message in addition to all of this, that despite the lack of a benefit in terms of the outcomes that you looked at, I mean, there's a clear need for all of these patients to have aggressive secondary prevention, and we know that, you know, patients going home on a statin after coronary surgery are more likely to be on a statin long term, and so you know, we don't want to kind of mix the messages here in terms of, you know, most of these patients had coronary disease, and so there really is an important challenge there.
Yes.
Yeah. I mean, I used to get very upset when someone was not put on a statin when they were referred to surgery. And I may get less upset now, but I will still be very upset if someone is discharged after coronary surgery and not on a statin, because the evidence there hasn't changed.
Absolutely. So Paulus, take-home message?
Well, there are two take-home messages. One, the pleiotropic effects of statins do not prevent post-operative atrial fibrillation in a very well-conducted large randomized trials. And therefore, either inflammation is not that important for AF as we thought, or statins are not the best intervention to reverse that.
Okay, and Barbara, final comments?
I think that there are many very good reasons why these patients should be started on statins, but prevention of post-operative complications is not one of them.
Great. So congratulations on a wonderful trial. I agree, it's just a phenomenal effort and a wonderful message of the importance of doing global trials and working across continents. It's a wonderful result, so congratulations.
Thank you very much.
I'd like to thank you for joining us on EHJ today, the Voice of Leaders.